we've got an individual with low back pain, we often have a limitation of movement or asymmetry of movement. And so we can regain some of that movement with exercise. But exercise itself can be very important in terms of symptom modification. So with our McKenzie approach, we talk about repeated movements, or repeated mechanical strain, trying to alleviate the symptoms. And by alleviate, what I mean by that is either to reduce the intensity of the pain or to change the site of pain. And we talk about centralization of the pain. So if you have an individual who has low back pain which is referred into the leg, if it comes right down into the foot, then we would determine that that was more severe than an individual who had pain coming just down into the knee, for example. So as the pain starts to resolve and the condition starts to resolve, we would expect the pain to centralize. So the patient comes in and they say, well, I've got pain, and it travels down the leg to the foot. As we do the exercises, we want that pain to travel down the leg just to the mid-thigh, for example. So that's centralization of the pain. And the other way we could judge improvement is the intensity of the pain. So we say, well, if we are assessing a numerical rating scale, with 10 being the worst possible pain, if that pain comes in as an 8, we want to do the exercises and reduce that pain until perhaps it comes down to a 4. So it's important to explain that to the patient rather than simply saying we want to get rid of your pain. So it's the pain behaviour rather than the pain itself, which is important. So the first exercise we're going to do is extension, and we've got our subject lying in prone so that the spine is supporting, and we want to perform the exercise passively. So this is not a strength exercise. So I'm going to get her to move her arms into a push-up position. So if you pop your hands down flat, just go down flat, because although you're bendy, your patient won't be. Elbows are coming out to the side, and all she's going to do to start with is to press with the arms to bend the spine. So we're aiming to keep the spinal muscles as relaxed as possible. So if the patient complains that it's hurting their arms and shoulders, that's a good thing, because it means that they're using that aspect. As the patient gets increased range of motion, she can come up further. So if you now try to straighten your arms, and we've got this increase. Now, we've got a little bit of a hyperlordosis here, so we don't want to emphasize that. So I would just drop her down and say, well, okay, we're going to stop at that position where we've got our nice curve. So that's our extension movement. If you spin yourself around onto your back, and we're now going to do a flexion movement. Now, if she's standing and she reaches forward to touch her toes, then that's spinal flexion, but it's spinal flexion from the upper lumbar segments first. So L1, L2 will move before L4 and L5. In this position, she's going to initiate the flexion through a posterior pelvic tilt. So we're getting the lower lumbar segments, L5, S1, L4, L5, moving before the upper lumbar segments. And it's important to identify which sequence of flexion is giving rise to the patient's symptoms, because we want to reproduce that. So we're going to draw the knees up, and if you take hold of your knees, now if she's got knee pain, we would grip underneath the knee, but if she hasn't, we can grip on top. And the action is not just to squeeze the knee in, but to try to lift the tail. So with the patient's permission, I'm popping my hand under the sacrum, and I'm just encouraging that movement to lift up. So we want that sacral tuck movement. Now you try and continue that, lifting your tailbone up. That's fine. So I'm trying to get her now to lift off my hand. So that's our flexion movement in lying. And then thirdly, we can have a rotation movement. So what we do is we straighten one leg, and that then becomes the fulcrum. So we want that to be in line with the spine. This knee comes over, and you have to sort of tuck the hip underneath. The hand comes down onto that knee. Now she's moved a little bit too far, so I'm just going to withdraw you again. So that shoulder wants to stay flat, and that can come out into a T position, or in this case, a half T position. The weight pushes down onto the shoulder, and then the leverage comes around here. So we're encouraging that lengthening of rotation by pushing down on the knee. And obviously we can play around with that, so we could use a gentle oscillation to try to reduce the pain. We can use a continuous static stretch. We can impart a neurodynamic stretch by straightening the leg. So there are various different modifications that we can use on that exercise to try to focus onto the patient's specific condition. So you've got extension, flexion and rotation.